idea.
All right, guys, we're back with another episode of Coach's Corner. We're shifting our kind of mindset from hormones and looking at those type of things to now we're going to be focusing a little bit more on exercise from a health perspective, longevity perspective, and treatment of disease kind of perspective. So it's a very holistic approach of exercise, nutrition, and all those type of topics to not necessarily yield someone the highest performance levels, but to help improve their quality of life, help improve longevity. And today we have on Ciaran, who's an expert in that topic. And then me and Paul will kind of try to be as much of an interlude and dumb it down and say some stuff that doesn't make any sense. And you'll be able to correct us. So we appreciate your time, man.
Yeah, man. Excited to be here. I'm really excited to chat to you. I think the more people that are trying to get into this space, the better. So whatever I can do to help people out, more than happy to do so.
Yeah, it makes sense that you're interested in this field, being that you hear that accent and you're like, man, he must see us Americans and be like, we need as much help as we can get. This will be a great field. I'll be employed for the rest of my life as long as I deal with Americans and health and exercise.
Yeah, exactly.
I thought it was a very kind of worthwhile pivot from where we've been going before, because a lot of the time when we deal with powerlifting, we deal with physique enhancement, we deal with all these things, we forget that exercise is our primary means to maintain or improve our health. When we look at performance sports, performance and health are definitely not synonymous with one another. Obviously, the healthier you are, the higher your ceiling for performance. But when we're looking at health in general, pushing for highest levels of performance is definitely going to come at a detriment to our health. So Dr. Fairman is a very interesting bridge between the research side and the practical application side, primarily in the area of exercise oncology. So dealing with exercise and individuals who are suffering from cancer with regards to their treatment. Maybe you could dive in a little bit to like your background and how you got into the field you got into.
Yeah, I think it actually aligns well with kind of what you've been doing in recent weeks as you head into, performance through hormones and now into health and disease. My background and my education was predominantly in sports science and strength and conditioning. So I got my master's in kinesiology at Georgia Southern, working in a body composition lab under Dr. Christina Kendall. And we did a lot of sports nutrition supplementation work in athletes. Then I went up to Ohio State and got my PhD at Ohio State. And again, was kind of in and out of clinical world. My advisor was Brian Fogt, and I also worked alongside Bill Kramer's lab. So, got to work with the world's strongest men, all this type of stuff, and really see kind of elite ends of performance. And it was fascinating. And at the same time, I was kind of having this growing interest in the oncology space, where the more I was learning about it, the more I was learning about how the different types and doses of treatment impact the body, and how those mirror a lot of the positive side effects we would see with exercise. And in particular, my main umbrella as it is now is resistance exercise to target body composition in individuals with cancer. So the umbrella of resistance training and body composition has been there since I was an undergrad. It was just taking it, seeing similarities in a different population and realizing the opportunity there. And some of it came from looking at the sports science field and strength and conditioning field and almost looking at myself and going, I'm going to be somewhat of a small fish in a big pond in there. And that I didn't necessarily have the angle or the passion to keep going further into that space and craft a niche to be able to have something new and innovative in that field. Whereas when I started to read the oncology literature, it's so underdeveloped, particularly in relation to resistance training, to where I was like, if I take my knowledge of programming, resistance training, all that stuff, and take it in this space, not only can I keep doing my passion, but the impact of that is magnitude folds higher of what I would do.
Yeah, for sure.
So one of the biggest things, I'm not necessarily I'm known for because I'm a nobody, but one of the biggest things I'm passionate about is properly structuring resistance training programs. So scale it back. We know that certain types of treatments can impact body composition and physical function and cardiorespiratory health. But in my context, chemotherapy can directly impact skeletal muscle signaling, leading to muscle wasting. Hormone therapy for prostate cancer, androgen deprivation therapy, testosterone is a key driver of prostate cancer growth. So the treatment is either stop the production of or the action of testosterone. Castrate men, inherently ton of muscle loss. So it's a fairly intuitive that resistance training will be indicated in those settings, but not a lot of people have our background in actually being able to design properly structured training programs. So my big goal when I first jumped in, damn near 10 years ago now, was I want to do resistance training in cancer. And she started to do the systematic reviews and all that stuff, and basically found that the field in general had a lot to move forward with in terms of the structure and programs of the training programs, because people weren't implementing or reporting progressive overload. The overall structure of the program wasn't necessarily designed to elicit hypertrophic responses. And then those studies get lumped into the broader field that if you implement a very gentle training program and you don't progress it, of course, you're not going to see the outcomes you want. But if you truck that into a meta-analysis, then people are going, well, resistance training doesn't do anything for muscle in cancer. And you kind of go, well, does it? Or is it just that the programs aren't properly designed? So for the past 10 years, I've been focused on trying to raise awareness in the field, in trying to design training programs better. And now I'm at a point where I'm collaborating with different people to implement those programs and really learn how much of the null effects is from the disease and its treatments versus how much is it from shy programs that aren't properly designed.
Yeah, I mean, that's something beyond just what you're doing that I see within the literature as well. It's just like people's inability to actually know how to intelligently design programs when looking at the research, right? They're coming to these conclusions of this exercise or this program is eliciting this result that's better than this program or this exercise. And it's like, well, you're not even quantifying the reps. You're not even checking out the morphology of the human being. Your program looks like you just copied and pasted it from a Flex magazine. Like, have you ever trained anyone before?
Yeah.
And that's just something that always, like, it's nice to see that blend of someone who actually has done it and is actually incorporating it into the research so that we have better research to look at, because there's so much research out there where it's like, I've been in your lab. I've seen the way that you conduct the strength training programs, in quotes, and it's like, it's garbage. Like, it just doesn't make any sense. And of course you're whatever you're finding is not going to be replicated by people who are actually training. So it's nice to have that gap being bridged, and especially when it comes to something that is actually meaningful. I always joke that me and Paul, we've worked with a lot of strength athletes and performance athletes, and it's like, that's the most meaningless job in our department, right? It's like, we're not fixing anyone, we're not curing anything, we're not helping people live better lives. We're actually probably derailing their quality of life just to get them to perform at a high level for one day. So it's nice to see that. But that's great that you're doing that, and that you're actually being able to shift maybe some of the meta-analysis or the systematic reviews and shine a positive light on resistance training for disease populations.
Yeah, and I think indirectly it's a way of making me sound more novel than I am, because all I'm doing is copying and pasting principles from strength and conditioning, bringing them into the clinical world. And they're like, this is mind blowing. It's like, yeah, 15 years ago in strength and conditioning. But I think you're also facing a lot of misconceptions. So airfield, and I would confidently lump any sort of clinical population into this, COPD, diabetes, whatever. I think those fields are predominated by people who are either, have physical therapy backgrounds or, are coming up or in labs, kind of to our point earlier, that haven't necessarily had a strong resistance training background. So you're not just, are you going against program design, you're also going against their misconceptions and fears of actually loading people. So, my general mantra is like, don't be afraid and don't put your own fears on people. Let's see what they're made of. And like, we all kind of, if you're trying to see where people's kind of red zone is, you have to touch that a few times. Right. Whereas the misconception is Ciaran's telling everyone to, do heavy training, heavy back squats and all the rest of it. It's like, nah, some of them are so deconditioned that, a 3-rep body weight squat is their max or their heavier loads. And it's less about what their perception of what heavy training is and more about how we progress them to there. Because we've had people go from not being able to get out of a chair, to being able to deadlift 100, 150 pounds on a trap bar at the age of 80 plus years of age. And that is essentially why I do it. Like, that progress is some of the most rewarding things about my job, in that you take people who previously are untrained, told by their oncologists or medical community to chill out, you've cancer, told by all their family and friends to chill out, they've got cancer. And then all the changes that happen with treatment are essentially accelerating decline. So once you become bedridden, you're stuck there. Or once you get the couch syndrome, where, you know, you stop performing ADLs, get stuck on the couch and all the rest of it, you just assume that you're going to be there for life. Whereas seeing people lose walkers or lose the ability to have assisted walking devices and all the rest of it, it's phenomenal, man.
Like that you mentioned that you can lump all clinical populations in there, because like when we look at longevity, I think it's like balance is one of the key indicators of longevity, because as soon as you start falling and you can't get up, you know, you're more likely to pass away. And one of the best ways to do that is through strength training, to maintain your proprioception and things of that nature. The immediate question that jumps out to my head when talking about resistance training and cancer, for like to keep it here, is recovery capacity. Mm-hmm. So it's like we have these very detrained individuals who are now in a diseased state. How, like, is part of your work to establish like a dose response or maybe a standard of care with regards to resistance training?
Yeah, that's the ultimate goal, is to kind of contribute to that body of literature. And there's so many really interesting questions around it, because the recovery response and the alterations in the immune system and all the rest of it is going to be dependent on the type of treatment they receive, how often they receive it, and the dose. So, for example, chemotherapy for earlier low stage breast cancer is nowhere near as toxic as it would be for late stage colorectal cancer. Or if you have head and neck cancer, you tend to have all of that combined with radiation in a lot more condensed period. So, for example, we know breast cancer is a fairly slow growing tumor. So you could have a cycle of chemo refers to your day or your period of infusion, followed by the subsequent weeks of rest. So you're after being wrecked by chemo, you need a few weeks to chill out and get your body back to normal, and then you get another infusion. So the infusion with rest is called a cycle. So in breast cancer, that could be 6 cycles across 5 or 6 months. Whereas in the context of head and neck cancer, they could have 4 or 5 cycles over the course of 6 to 8 weeks, in addition to daily radiation therapy. So I'm going to actually argue with myself here and provide you an example of the extreme opposite end, where consider you've got head and neck cancer, anything above the neck that's not the brain, it's head and neck cancer. So you've got part of your jaw removed, you've got radiation to your throat, so very difficult to swallow, eat, all the rest of it. Getting systemic chemotherapy through your body once a week, and you're getting daily radiation to that area once a day. And then imagine either trying to train and or fuel that training session or recover for the next one. Mm-hmm. They're looking at weight loss rates of 20 kilograms across 6 to 8 weeks. And then you're saying, right, now this is a 65, 70-year-old with other comorbidities, right, shoulder from high school football, bad knee. It really starts to stack up all the challenges that we have in actually overcoming that, to the point where there's actually a condition called cancer-related cachexia. And the overarching definition is that it's an aggressive muscle wasting disease with or without fat loss that can't be ameliorated or reversed with traditional nutrition counseling. Well, if I just explained that head and neck scenario to you and I said, sorry, dude, you're losing a bunch of weight, have you tried eating more steak? You're going to go, yeah, fuck, like, that's not going to do
half my jaw.
Yeah. To the point where we're actually working with some preclinical researchers here that do a lot of muscle wasting models in mice. And where we're at now is that the preclinical research, oftentimes it's hard to give a mouse tumor and chemotherapy and a different treatment because the tumor grows so quickly it kills the mouse. So what happens is researchers will study muscle wasting in the context of one chemotherapy agent, and they'll look at whatever intervention or therapeutic they're looking at. And it's really exciting to start to look at mechanisms of wasting and potential therapeutics. But when you try to translate that out into someone who is receiving hormonal therapy, chemotherapy, radiation at the same time, and all these other factors, in addition to the financial toxicity, the depression, all the other stuff that comes with a cancer diagnosis, you start to stack up all these things and go, it's actually really challenging to get someone who's never trained before, get them a stimulus sufficient enough to support muscle growth, support that stimulus with nutrition, and recover well. It's what is so fascinating about the field to me that keeps me driven in it.
Seems like just a constant problem solving equation.
Yeah, and it kind of go back to your point, like so many of the questions, I think you could still have the same questions in healthy population in terms of dose response, frequency, all that type of stuff. And it's the exact same thing, just in a population that to me gives me more reward. And I think the field of exercise oncology is about 10-15 years behind cardiac rehab, where they're starting to see a recognition of, well, maybe with all these physiological changes with treatment, it's best, or it's not as best to rest and recover as we used to think. Maybe we start to get people trained as early as possible, to the point where we developed kind of like phases of rehab, much like cardiac rehab, where we've got prehab, on treatment work, post-treatment, and all the rest of it. But at the same time, it's been very cardiovascular focused since its inception. So it's a new enough field, with the first work published late 80s. So 30 years ago, and only in the last 10 years have people, 15 years have people really started to do resistance training. And then only in the last 5 years I've started to see an improvement in the quality of those programs. So it's kind of, to your point, what I see in the future is just dedicating my life to figuring that out and trying to contribute to that literature to help people understand the benefits and potential limitations of resistance training in that context.
Yeah, so I guess my question would be then, in terms of like the benefits of resistance training for dealing with diseased patients, right? It's like, what exactly are you trying to achieve by implementing these resistance training protocols? Is it just to improve the quality of life, just to preserve muscle tissue? Are there anything that you would think of that could be like deleterious with resistance training, right? Because with the anabolic signaling of resistance training, you may have spikes in IGF-1, and that could cause more growth within the tumor and things of that nature. So how do you kind of combat all those things?
Yeah, it's a really interesting area, and it's funny. I've been collaborating with Mike Sordos of Florida Atlantic on a couple of programs, and
Okay.
we designed a program where we're looking at auto-regulation versus linear programming or whatever. And the main outcome was strength. And we're kind of saying, like, if they can adhere to it better, they'll increase strength. And say there's a 40-pound difference between groups or whatever. We in that field, in the strength and conditioning field, that's the outcome. This program is better at improving strength than the other program. And in the medical field, they don't care.
Right.
Like, there's no doctor on the planet. There's very few doctors on the planet that will say, well, maybe you should consider this training program versus this because there was a 40-pound increase in strength. It's just kind of like irrelevant in broader context. So it's like, well, what's after that? Is it, I think, predominantly in the context of resistance training, I would say behavior change is a big outcome, in the sense of, you came to our lab for 8 to 12 weeks. We got you the changes that we needed. But, Mary or Latoya lives out in rural South Carolina, and they've lost access to our lab and our expertise. And they're afraid to go to the gym after work because they live in a rural area and it's dark after work. Like, that's a huge kind of beast to tackle, where I've been really tasked with or challenged with the idea of, like, I came into it super heavy in terms of like physiology and just like specific outcomes, whether that's physical function, whether that's a frailty index or anything to my mind that keeps them out of a disability condition.
Mm-hmm.
But then inherently, when you're in these more clinical settings, you're introduced to disparities and all the rest of it, where then you're starting to go, like, on a bigger picture, is this trial the one that's going to change, practice and kind of the idea of efficacy versus effectiveness, in that my program might have efficacy, but is it effective if I put it into the community setting? And then how do you compare the magnitude of change that you would expect in my lab versus I sent Latoya down to the local Y to get her into a training program? So that was a really long answer to be like, I'm in that period right now of trying to figure out what's next in our field at large of like, is it more important to figure out a better way to do a training program, or is it more important that more people get access to resistance training in this context? And as an ever ongoing debate in my head.
Yeah, I bet, man. That's one of the biggest things when it comes to coaching in general is like you get these people and they pay you for your expertise and they rely on you. And then your job as a coach should be to have them leave with the full understanding that they're capable of doing this on their own. But when you go into like a clinical set, well, most good coaches have that. Other coaches are like, I don't want to give you all the information so I can make a living for the rest of my life. But when you have like something in the clinical setting where they're already kind of vulnerable, they're already kind of not really on the right track to begin with, and maybe they've never resisted train before, you introduce them to all these things. How are you able to, or what are you working on as far as like interventions go to allow it to go from clinical to actual practical on their own? Is that something that you're looking at within the literature? Within like your, like, I wouldn't even know how to set that up from a scientific research perspective of the efficacy of the program, like 8 weeks of training, and then they do 8 weeks of offsite training on their own, and then they come back and which program they were able to adhere to better. Are you guys looking at stuff like that from an adherence perspective?
Yeah, we're starting to. My PhD at Ohio State was in a behavioral lab. So we did a lot of that, adding that component to our intervention. So again, came in like super me head, squat, bench, deadlift, everyone has to lift heavy. And my advisor was like, you're a lunatic. And one of the things to your point earlier, in the peer-to-peer support is really important. Most of what we do is in smaller group settings of whatever, 3 to 8.
Mm-hmm.
And the power of that is not necessarily just general social support. It's more in the context of the disease, in the sense of I'm a relatively healthy younger dude. There's no way I can relate to someone who's in their 60s with breast cancer, or in the context of prostate cancer, has body image issues, incontinence, sexual dysfunction, all these other things that if you can put them around themselves, even just having a chat here and there and having that peer-to-peer support is really big. The second thing that we look to do, and again, saying it to you two, it's not novel. Our program generally is hinge, squat, push, pull, some sort of core movement. Fascinating.
Yeah.
But super nuanced.
Yeah. You might want to start taking notes.
I am.
But one of the reasons for it is twofold. One, to show our field that it's okay to train free weights. It's okay to get away from the machines, because I can tell you that the majority of exercise oncology literature is seated row, chest press on a machine, leg press, leg extension, leg curl. That's it. And there's no deviation for that. And you could look at those programs for anywhere from 3 to 6 months to a year. And it's like, should be like, doing that much for a year.
Right.
Whereas I'll give a nuanced little point to this in a second, but having the hip hinge and the squat and all that stuff allows us to individualize the program to the participants, but also throughout that, we're educating them on the movements and trying to start push them across the course of the intervention of, look, this is a hinge movement, so pick what we've been doing. What is the hinge movement? And if you go to a Y, or if you go to another gym and they don't have this specific piece of equipment, what else could you do to replace this? So the idea is the first few weeks is a familiarization phase of us getting used to their loading and all the rest of it. A couple of weeks after, we're starting to slowly back away and lean more towards them trying to lead the sessions. And towards the end of the session, it's more asking them all the questions of like, here's what we're doing. Tell me, or here's what's on your sheet. Tell me what you're doing. Pick the exercises. Tell me if you feel anything with your form, and trying to foster that independence and autonomy. By the point where they come out of the program, they have kind of that confidence. And then the outcome after that would be maintenance of activity and maintenance of outcomes. So do they maintain their strength and do they maintain their activity 2 months or 3 months down the line?
Yeah. I like that. That makes a ton of sense, right? The educational piece is so important so that they're able to discern like hip hinge does this. There's a million varieties of hip hinges. If one's not like, if you just put someone on a machine, it's like, I only know that this is the machine that I've been using for a year. So if that machine's not available, then I just don't know what else to do. Right. And that's the same thing with meal plans with people. It's like, this is your meal plan. And like, oh, I can only lose weight if I have 12 almonds and 5 asparagus and 5 ounces of chicken. If I eat anything else besides that, I'm going to get fat. And you're teaching them how to be autonomous, which I think is so important from a coach to athlete to any type of individual perspective, is giving them the confidence to go into a gym and know exactly what they're going to do, even if it's not the same setting. I think is setting them up for success, which I think is extremely important. Do you guys also look at food adherence as well, or are you strictly just resistance training and focusing on that side of things?
It depends on the study. So I've got an ongoing trial finishing up in Australia at the minute where we looked at creatine and resistance training and prostate cancer. And we had, I mean, look at food adherence. You're looking at FFQs every few weeks. So it's food frequency questionnaires. It's nothing intensive. We are in the process of applying for grants to have a lot more in-depth analysis and tracking of food as well for a couple of grants we've got coming up, looking at more specific muscle wasting conditions that we think the nutritional profile will have a really big impact. One of the really interesting parts of the oncology world, at least the people that we're applying to in terms of funding, is being very mindful of participant burden. So 20-year-old interested in getting jacked, do whatever you tell me to do, I'll do it. 65-year-old rural South Carolina, low SES, is not maybe going to have the capacity to get enough nutrition anyway. And then you're going and looking at changing people's diet, their potential cultural aspects in terms of their relation to food and all the rest of it. So it's a challenge between how much can we intervene and what's that participant burden look like, which is one of the reasons I've kind of gravitated close to creatine and other supplements that we think can be minimally invasive, if you will, in terms of the burden that would be on the participant and seeing if it can add to our training. But I wouldn't discount the value and the role of tracking nutrition and having more targeted interventions.
Yeah, I was going to say, especially coming from like Ohio State, where Jeff Vogel is doing all the research on ketogenic diets. And sometimes there's a positive connection link between ketogenic diets and cancer and things of that nature. So I didn't know if you were exploring that. I know if you're doing resistance training and it's such a misrepresented field, you have your work cut out for you. Like that may be the gist of your career, is just focusing on resistance training. So then to also look at nutrition intervention would be maybe a bit of a pull. So I was just curious if you guys did any of that.
Yeah, and I think the other challenge that I've kind of increasingly appreciated is my limitations in terms of my nutritional expertise, in the sense of some of the grants you've got coming up have registered dietitians with specific expertise in oncology on them, whereas given all the challenges to getting adequate nutrition in that field, I think they would need a more comprehensive nutritional evaluation anyway. Really interesting about the Volic stuff with keto. I was at Ohio State when they were running that trial, and it was ketogenic diet in metastatic breast cancer. And the theory and the philosophy of it is very interesting in being able to, quote unquote, starve the tumor, increase the treatment efficacy and all the rest of it. The reality is that trial is not going to be completed the way it was intended to, in terms of being able to recruit people with metastatic disease to go undergo a full nutritional intervention. Like the food kitchen that Volic has is state of the art, and they cook people's meals every 3 days and give access. And even then, they're still having trouble in people during this intensive period. And I say the same thing for exercise as well. Like, step back, bigger picture at it, and think about like parents, close family, or whoever has gotten a cancer diagnosis. And very few of them remember specifics about the day they've got diagnosed. So you've got cancer, we have to go into treatment next week. Here's your chemo or patient education, or she's going to tell you all the stuff about your treatments. Here's your social worker, here's the insurance company, here's all the financial stuff. and you're going, what the
It's a lot. Yeah.
do I tell my boss? How do I tell my partner? Do I tell my kids? I don't know anything about cancer. Am I going to die? Am I going to keep my job? And we go, hey, have you tried squatting? You know what I mean? So one of the biggest challenges of the theory versus the reality is just managing all that stuff in how do we actually recruit people to the trials to determine the efficacy, which is very difficult. Not to say that it's not a valuable pursuit, but it's just so difficult that, to your point, I'm already having a hard time getting resistance training off the ground and appreciated that. It's just kind of like, what's first?
Yeah, I really love how you highlighted, like I'm kind of thinking back through and taking notes on a few things that you've said, and the amount of parallels between what we do as coaches with Gen Pop clients and what you're doing as a coach or a researcher with diseased populations. It's like we're teaching them about progressive overload. We're figuring out what they can recover from, and then we're going to progress them as tolerated. We're educating them along the way, and then we're going to lead them towards some form of autonomy, because as Tony said, like after they're finished their treatment, they're healthy. Well, they should continue to train for their quality of life, but do they have the tools capable for them to do that? And the other piece that I was wondering about is, like, people are always talking about exercise as a means to improve mental health. And we know that the mental health roller coaster of a diagnosis of any kind, as you mentioned, insurance, cost, family implications, things like that. Are you guys doing any sort of like mental health outcome measures with your resistance training interventions?
Yeah, we'll do both qualitative and quantitative, because the quantitative measures are fairly generic and very seldom specific to training. So there's a lot of cancer specific quality life scales. And it's kind of like, how does your disease affect your mental health? Do you feel supported by family members? Blah, blah, blah. Really important outcomes in the context of cancer, but aren't necessarily going to capture the interaction between resistance training and health related quality life outcomes. Right. So we usually do qualitative interviews after the training to see, what their perception of was resistance training, if and how it changed, how they feel that impacted aspects of their quality of life and all the rest of it. And in general, you'll find, at least in our lab and replicated by others, they've done it first, other people that we're cheating from, finding similar outcomes in terms of, I was nervous to do it, didn't really have a lot of self-efficacy in that space, didn't know what to expect. I feel a lot more confident in my abilities, reduced fear of falling, overall quality of life in terms of being able to move about their daily life better. So again, to your point, not too dissimilar to what you're trying to achieve. And like, did getting stronger make you feel better? Shit, yeah, it did. So yeah, that's kind of one of the aspects that we're doing. I'll come back to your point about treatment in terms of the recovery stuff. So again, not novel at all, but one of the ways I started working with Zordos was all of his auto-regulation stuff. And it makes so much sense when you think about physiological and psychosocial stress being at its highest and readiness to train being at its lowest. If there's any population that needs that, it's someone going through chemotherapy, radiation, all the rest of it, where sleep is off the charts all the time, fatigue is all over the place, nausea is all over the place. So on any given day, their preparedness to receive a training stimulus can be all out of whack. So again, integrating some sort of auto-regulatory model can be beneficial in both the stimulus and their ability to recover from it, but also their perception of the fluidity of the program. Because if we lined out that program for them and we said, look, you're doing X by X sets and whatever, and not giving them any flexibility within that, they're sitting in the car going, fuck this, like I'm wrecked from treatment, haven't eaten in 2 days. I'm not going in there to do a high volume session.
Your adherence is going to be zero, which is adherence is the only thing that you need.
Yeah. And it's really funny. So I know, again, a lot of people in sports science are looking to develop better ways of tracking training and load and all the rest of it. The predominant way of measuring adherence in oncology is, did you walk through the door? And one of the biggest things that we've kind of looked at as we review the literature is that it's almost irrelevant. I'm a researcher by mistake. I was a personal trainer, strength conditioning, all that type of stuff. And the more I read in oncology, the more I was reporting these beautifully laid out programs and had all their sets and reps down. And all that is what the researchers programmed initially. There was no reporting on what people actually did. So they're saying, we did this program for 12 weeks and the adherence was 85% because 85% of the people 85% of the time they walk through the door. But we all know, like, I can drag you kicking and screaming to the front of the door and walk in. That doesn't tell me anything about the training and stimulus received. And the further I went on in oncology specifically and working with people on treatment, I was like, there's no way they're, even if they're getting through the door, they're getting all the sets and reps that you're saying they are, or they're within that proximity of failure or whatever. So we very, I say basically developed like a volume load metric where we quantified it as relative dose intensity. So what did we prescribe as a function of volume load? So sets by reps by weight for every exercise, for every session. I said you were going to do 20,000 pounds today. You came in and you're absolutely wrecked. So we took a set off every exercise and we dropped the weight by whatever, 10%. So now your volume load is, you've done 60% of what I asked you to do. But if I keep reporting that you just walked in the door and you consistently hit 50, 60 RDI of what I actually asked you to do, you're getting half of the program. Mm-hmm. But I'm going to report that as 100% adherence if you show up all the time. So I think there's a huge mismatch in, again, coming back to, depending on the type of cancer and the stage of treatment and a stage of disease and the treatment they get, there's a disconnect between how much cancer and its treatments impacts our ability to respond to training versus how well are we actually quantifying what they're doing once they walk in the door.
I think you're missing a big piece too, because if you're not capturing that RDI, as you mentioned, like how much they're actually able to do compared to what's programmed, you're not going to get a really clear picture of dose response.
Exactly. And one of the things that the bigger picture for me would be able to start profiling almost trajectories of RDI or recovery across different treatment types. So if we know that people getting chemo for breast cancer with corticosteroids to buffer some of the kind of immediate side effects, they might get some anti-nausea medication. And once those start to wear off after a few days, then their symptoms might peak in terms of their, psychological distress and nausea and fatigue and all the rest of it. So if we can build, if people adopt these metrics, we can build profiles of, here's general recovery curves in terms of chemotherapy for breast cancer versus head and neck cancer chemo radiation. You're in this constant alarm state. So we need to find that balance of what's the minimal dose we can give you to provide some sort of stimulus, but not too much that's either catabolic or expending extra calories that we don't need to expend when we're already in that kind of catabolic state.
You could almost even figure out some sort of index based on like the chemo cycle of when to administer, like between this day and this day from the administration of the chemo, this is when your training response is going to be best. So those are going to be our heaviest days, and similar to like an in-season program for like a team sports athlete where, like, hey, the day after the game or the day of the game, we need to bombard that stress, offload them, basically building out like a high-low sequencing for cancer.
Exactly. And it's in its infancy. I'd confidently say there's less than 5 of us in the world that have the resistance training background knowledge that's being applied to oncology. And we're all saying the exact same thing. We're all trying to figure out similar stuff of, right now, it's our best guess of anecdotally, I've seen this in other people with this similar type of chemo, so we're going to modify a training program. But I think there needs to be, one, much more people in the space, and two, a much bigger body of evidence that we can build to support these decisions. That it's just educated guesses at best right now.
So you've got like 5 other strength coaches, including the 2 of them who are interviewing you, listening right now. So like elevator pitch, how do people get involved?
I think try it, man. Like I don't know how many people. Well, I'll go backwards. A lot of people go into this space being wanting to work with physique athletes or wanting to be an elite sport, and I don't think people get enough experience seeing the value in taking those principles and applying it to populations that don't normally get it. Because people might have gone to a physical therapy clinic in undergrad and being like, PT is not for me. Well, we know there's a boatload of great PTs that now have strength and conditioning experience that are excellent in progressively overloading people. We also know that there's emerging labs in clinical populations and in aging that know how to do resistance training properly. And I think the environment that you're in will dictate your experience. And like, I could send you to some lab that does machine-based exercise, no progressive overload, and you drive yourself nuts. You're like, this isn't for me. Whereas the fulfillment I get from working with someone who's never trained before and they're undergoing this intense treatment, everything in their life is negative. Like they're worried about, is their cancer going to get treated? They're worried about when they get a scan, is there recurrence, updates on disease and all the rest of it. We can be one of the only positive sources of energy in their life. And it's really powerful to work with those people. And I think at the same time, the more people that work in that space, the more you realize we can work them a lot harder than what we give them credit for. So people would see our participants deadlifting and stuff, and they'd be like, you know, they've got cancer. And it's like, yeah, they're receiving toxic drugs flushed throughout their body. Doing a few hip hinges isn't going to kill them. You know what I mean?
It's funny you say that, because like, so when I was in the collegiate strength space, I got out of that space, and my transition was actually into disability rehabilitation. I worked for an insurance company as a consultant, and it was essentially working with people who were off work due to varying disabilities from physical to mental health. And at first I was like, I have no idea if I'm going to enjoy this at all. But exactly as you said, the impact that you can make on someone's life who is potentially being told by a number of people that they are done, their best days are behind them, they can't get better, or this is their life. And then you go ahead and make some small impact, or some like seemingly small impact that has ripples throughout. The amount of, internal validation that you get from that victory for that person, I think most people who try to pigeonhole themselves into physique or performance are really missing out on that.
Yeah, and I think I add to that in the sense of people will automatically go, well, that's boring. I don't like training soccer moms. I don't like training clinical populations. So that's boring. Well, we've just spent half an hour outlining all the reasons why what I do is very similar to what you do. So why is it boring? Is it that you're not able to push these people the same? You're not be able to create a rapport with them? Like, what is it aside from, being in competition and seeing people succeed? You can still take a lot of wins from getting someone to the point where they've never trained before, don't know anything about movements. And then if you can get them to stay active for a couple of years, man, that's gold.
I think the most fun thing about what we do, and I think this Tony will agree with me here, is the problem solving.
Yeah.
Right? Looking at this big, massive, complex equation of a person, their life, their job, their habits, their lifestyle, what they like doing in the gym, and then finding something that fits, they're able to recover from. You're doing that. Plus, you have all this other stuff going on. It's just another layer, 2 layers, 3 layers of complexity to the problem that it makes it more fun in some sense, just that problem solving aspect. And it seems as though to every question we've asked you within that context, you've also asked yourself a number of questions that go layers deeper than that within that same context.
Yeah, that I think to your point is what is so, rewarding about it, because the complexity is so high. To your point, like you've got comorbidities, cultural aspects, low SES, accessibility, physical limitations, psychology, and then you throw cancer diagnosis on top of that, and you're dealing with different stages, types of treatments, and all the rest of it. It's a really interesting puzzle. And also, I'm at a point in my career now where I have my own lab, and now I'm tasked with, it can't just be that I'm a good coach, and it can't just be that I've got a great philosophy. Now it's, how can I scale my philosophy, so to speak, by training these undergrads and grad students well enough to where I feel confident with them representing what we do. So it's a really interesting dynamic now, trying to educate people on the oncology space, in addition to all the other things that come with training. Because a lot of people ask about coming to my lab and say, well, you know, I've no oncology experience, and I'd rather take a seasoned or expert strength and conditioning professional, and I can teach you cancer stuff. But to me, it takes so much more time to be a good coach and have the experience to be a good coach, that you can come in with great cancer knowledge and it takes you way too long to understand how to work with people and figure out all those things intuitively, in terms of being face-to-face and problem solving on the floor as well.
Yeah, I think that communication piece is lost amongst a lot of people. And it's funny you say like people wouldn't think that it's fun. They think that training like professional athletes is going to be a little bit more fun. But it's like, you talk to those guys, good luck getting them to fucking listen to what you have to say, right? It takes years to build up, you know, their trust in you. But one thing I want to get to is kind of within the training program, what are the adaptations that you're finding that are moving the marker in the most beneficial way? Is it coordination? Is it hand-eye coordination? Is it you know, agility, side-to-side movement? Is it strength? Is it neural? Is it hypertrophy? What are you trying to, or what have you seen to be the biggest adaptations that you're building out within your program that's actually moving the needle forward for these people?
I think strength and physical function are kind of the main ones that we can change and are fairly sensitive, but also are relevant to the medical community. So one of the things we're tasked with in our field is identifying outcomes that doctors are going to look at, recognize and see value in. Because again, if I present, you know, 80-pound increase in leg press strength, they're not necessarily going to see or understand the value of that. Whereas if I say timed up and go increased by a few seconds, or we have, based on these, you know, older adult testing scenarios, we can identify people within a frailty or disability condition. And if we improve timed up and go and gait speed, we now get you out of that condition. So then we can report back to doctors and say, people going into our intervention, there was X% of them in a frailty condition, and now there's X% less. And they go, that's really important, because that, in addition to quality of life, resonates with them. At the same time, there are some really interesting work going on across the country, really looking at things like balance, coordination, and even neuromuscular adaptations as well, that I'm really interested in. I'm a more applied lab and focus anyway. So a lot of, when I start to dig deeper into that in terms of maybe biomarkers and or signaling and things like that, I'm starting to work with people like, say, Mike Roberts and Dave Church, who would be more experts in that area. We just get them the tissue and then they'll tell us what's happening.
Yeah. I think that's a good idea. I love the work that Mike Roberts does at Auburn as well. Really smart guy. We just read a paper of his. And the reason I like him is because he's a professor who doesn't necessarily just try to find the right answers to prove what he's thinking, but he'll just publish what's out there. Like he wrote a paper with Cody Hahn talking about sarcoplasmic hypertrophy and that it could be a real thing. And then he just published a paper refuting that. And it's like he has two papers, one saying it's a real thing, one refuting. And like that's what a real professor is supposed to be. That's what a real researcher does. And that's very few and far between these days. But I think that's awesome that you're doing that. I think so many people focus on like sarcopenia and hypertrophy and volume, and they miss the boat on coordination and strength training and that neural adaptation, which I think goes a lot further with the elderly population, the disease population, than trying to add on some muscle, right? Because I don't necessarily know if muscle is what is going to decrease the likelihood of them getting injured, or is it going to be their ability to catch themselves, strength and coordination, and that should be the main focus, right? And I think once you get away from hypertrophy being the focus, then you're going to get away from machines being the focus, and then you'll start to realize like these other things are moving the box far more forward than the volume training type stuff.
Exactly. I think I'd hold my hand up and say I got lost in that for a while as well, because the muscle changes are so interesting in terms of, you know, malnutrition, malabsorption, direct and indirect treatment influences on skeletal muscle signaling itself. You get to go, well, holy shit, this is the thing, we need to recover this or arrest this. And I think we can find the balance between providing a training stimulus to try and reduce the severity of loss, while also the outcomes matter. Like, it doesn't matter in terms of how little or how much muscle you lost, but what's the impact of that muscle loss doing?
Right.
Are you stuck in a disability condition? And I think that it makes my life easier because I'm not smart enough to figure out the rest of the outcomes. So I'm like, did you stand up and sit down more times? Great.
Yeah, exactly.
I think sorry, Paul.
No, I'm just like, I'm kind of just going through in my head. I'm like, there's so much shit going on here. And it's so cool.
Yeah, I think like we're really interested in all seriousness in really understanding how much we can actually reverse this signaling or arrest loss, and also what is causing the blunted adaptation. So we do start to look at some tissue or even mitochondrial changes as they occur during chemotherapy in particular, because chemotherapy destroys mitochondria. So that contributes to fatigue and all the rest of it. We're also looking at some really interesting acute studies of looking at immune response to single dose or single bouts of exercise during and after treatment, see if those look different. One of the most interesting parts of working with new people in this field, a PhD student now, and she was kind of saying, look, I want to do some heart rate variability on treatment and see if we can use that as a gauge of stress to contribute to autoregulation. And if you look at, depending on the type of chemotherapy you receive, anthracycline chemotherapy in particular, high doses of anthracycline fuck up the heart rate completely. Some cell death, some alterations in the signal, to the point of heart rate, measured resting heart rate on any given week can be up or down by a 20 to 25 point swing. So if that's what chemo is doing with the heart rate variability is fucked. Your ability to prescribe any sort of exercise based on heart rate is gone.
Yeah.
So she was kind of going, well, I want to do on treatment. And I was like, well, it depends on what treatment. If they're getting doxorubicin, no way. But maybe if they're getting taxane-based chemotherapy, maybe that's one that we can look at. Or if they're on hormone therapy, maybe that's something we can look at. So that is also, that layer of complexity is what fascinates me in terms of what type of treatment, how long are they on the treatment, how long does it take these alterations to occur? Is it best to do prehab versus just wait to recovery from after treatment and all the rest of it? So yeah, it's fascinating.
So with all those complexities, right, and within the realm of research, we're trying to single the variables as much as possible so that we can actually get data that people can use. How do you decipher that? There's so much going on. How can you actually have good research?
Yeah, it's so hard. The balance is what is enough variability that's acceptable. And I really struggle with this with our resistance training interventions as well. I went through like this crazy esoteric quarter life crisis of, we're doing these hinge, squat, pull and all the rest of it, and going, okay, Mary's getting one dose, John's getting another, Latoya's getting another, and they're getting different exercises and they're getting different doses. So if this was 500 milligrams of paracetamol or NSAIDs in an intervention, they're not getting 500 milligrams each. Someone's getting 450, someone's getting 350. So I really started to kind of get lost in that. In addition to all these cancer-related conditions, how much are they confounding the results, and men and women in trial and all the rest of it. And then you get to the point of going, the internal validity or rigor of the trial relative to the external, validity and all the rest of it. And I fall in line with if you scale down to a point where you have a completely heterogeneous population that you're working with, you won't do anything.
Right.
Like this is one of the things that I worked with Mike on a lot, where we were looking at like early stage breast on treatment, and it was just like you're recruiting one person every few months. So it's that balance between like how tight is tight to really have rigor versus too tight that you're not going to show much. And it's an ongoing battle in my head. One of the other things, the thing I was talking about cachexia, it's a really aggressive disease, impacts a lot of cancers like pancreatic, gastrointestinal, head and neck, lung, things like that. A lot of people in the cachexia space are trying to figure out, should we target the condition or should we target a specific tumor type and treatment? Because the mechanisms of cachexia are likely different across different types and stages of disease. But at the same time, again, if you're looking for only people with lung cancer who are cachectic, who are receiving targeted kinase inhibitors, and I'm in Columbia, South Carolina, I mean, there's 400 people diagnosed a year, quarter of them are metastatic, and then even less so have cachexia. So it's really hard to figure out. At the same time, I'll recognize, much like I did when I was working in sports science, is like the limitation being hard does not mean the limitations doesn't exist. So we say in sports science a lot, like low ends, it's really hard to work with elite athletes. Cool. Doesn't mean that the limitation doesn't exist. So it's really hard to recruit people with cancer to start an exercise program. And we have to recognize that heterogeneity is a limitation in our ability to kind of be conclusive in what we're saying from our studies.
Right, but sometimes you can get a case study to help develop the ideas of mechanisms. And then once you get the ideas of mechanisms, then you can develop an actual intervention to help like get out those mechanisms a little bit more, right? So there's validity in all the research you can do, but like you said, the more minute and detailed you get, you only have a sample size of 1 or 2 if you're lucky, right? So it's a tough thing to battle.
Yeah, I'm really leaning towards these. I don't know if you've heard like adaptive randomized control trials, where they tend to be a little bit more cost efficient and time efficient in terms of, you do a randomized control trial, and based on whatever you quantify as a responder or non-responder, responders and non-responders would then be randomized into 2 subsequent different interventions. So if you're responding, we either continue on the intervention or we'll implement something different. If you're not responding, then do we add a different component? So one of the things in the context of our resistance exercises, to all our earlier conversations of, does everyone need a complete dietary overhaul, banging every supplement I can think of in addition to their training? Or is resistance training enough to have a certain amount of people respond? And then the people who don't, do they then need additive interventions in terms of supplement, behavioral support, and all the rest of it?
Yeah, I like that, because it makes sense, right? Because when you're dealing with life and death situations, you can't just be like, oh, this person's not responding, but we're really going to run this. We're going to continue the 16-week program on them. We're like, fuck, you could kill the person. Like, you have 16 weeks. Like, let's try to find something different. So I like that flexibility. I've never heard of that before. So that's awesome.
Yeah, it's something I'm fairly new to myself, but the more I learn about it, the more it makes sense. And we're going to stick in a grant and they'll tell us to get fucked, and we'll do that a few more times before we get it funded. So we'll see what happens.
Yeah.
How do you standardize for the implementation of the program? So you mentioned, like, if it was a drug, some people would be getting 300, 350, 400, 500, whatever. If you have one person doing, a goblet squat, another person doing a bodyweight squat, or someone doing a barbell squat, how are you regulating or standardizing the way you consider that intervention?
I haven't come up with a good way to do that yet.
Stumped you, yes.
Yeah, and that was part of my crisis a few years ago, was like really come to that realization of, these people are receiving different interventions, and it's a hard thing for me to grasp, to wrap my head around, because I don't really know how you could, unless you scratch the load and just do volume in terms of sets and reps and stuff like that. But even then, it's a challenge.
Perceived exertion, maybe, or like relative exertion.
Yeah. Like what I at least what I tell myself, that so I can sleep at night, is, in general, if they're one person doing body squat and the other person can back squat, theoretically they would be receiving a similar stimulus relative to them.
Right. Yeah.
And basically that's as far as I got. And I was like, right, I'm just going to ignore that for the rest of my career.
Well, couldn't you, I don't know if you could, but couldn't you quantify that, right? If experts, if you test all their baseline, right? and baseline 1 is bodyweight squat, baseline 2 is a 135-pound squat. If each person increases by 20% of their baseline, then that's a 20% increase. So then you're saying like, okay, well, if we have a 20% increase in everyone, then all these markers improved, and all we needed was a 20% increase, regardless of the load or the intervention or anything like that.
Yeah. One of the really big challenges for us, and I haven't figured out a good way around it, is the variability in performance in terms of, like I was talking about before, of having like physical function outcomes. And one of the biggest challenges with those is that there's a ceiling effect for a lot of people. So in the context of some of our interventions where we might not have access to machines to do 1RM and stuff like that, I'm not going to staple someone under a back squat or under a free weight. So you're having null effects because of a ceiling effect for some people.
Right.
But then if we give the quote unquote the higher assessment for other people, it's not feasible. So it's a really interesting balance that I'm trying to figure out how to work around in terms of properly assessing the change.
Yeah. To like the variability of performance based on when they got their treatment.
Yes.
When like within that treatment cycle. That's really interesting.
Yeah. I was going to say something else there. But no, it was something along that point. But yeah.
So the big question is, when are you going to cure cancer? With squats.
This is the other thing that is fascinating about my field, because you're in these medical settings and people are like, this is Dr. So-and-so, this is Dr. So-and-so. And they're like immunotherapist. And I started this disease or this treatment and all the rest of it. And I was like, I have a whistle and I'm back home.
And a stopwatch.
Yeah. My mom tells people I work at F45. Like,
oh, discrediting all your academic and actual training credentials. I love it.
Yeah. Great way to keep your feet on the ground, though.
Yeah. She humbles you quite nicely.
I'm sure it's like a pretty cool dynamic to be walking in and being like, I make people lift weights and you are a crazy doctor surgeon person.
it's yeah. And you're also dealing with those personalities too, where, you know, some people enjoy being a real fancy pants doctor. Other people have no experience themselves with lifting weights. So they're like, what is this fella doing? My department chair is Sean Arndt, and he's well known in the sports science field, but the dude is jacked. And some of the people that I work with are over in the nursing department. And when I was interviewing, I was like, look, I have to meet these two people because they're big in my field. And you should have seen their faces watching, not necessarily me, but him walking me down the hallway to meet him. Like he's absolutely stacked there. Like, what is this fella doing? You know what I mean? So that's also why I've committed myself to not becoming too muscular. I like to stay in a nice.
That's why.
This nice approachable physique where, you know, not too intimidating. You know, there you go.
That's why I got knuckle tattoos.
Nice. Yeah.
Oh man.
Anything else, Paul?
No, I think that was that really blew my mind, to be honest. I'd never, you know, you think about oncology and you think about the complexity, but add in the layer of complexity of exercise as a treatment modality, I think it's really friggin' cool.
Have you ever worked with anyone where it was a negative outcome including exercise?
Oh yeah.
What do you think? What do you think the premise of that was? Is that they were just not able to recover completely, or was it something else?
I think a combination of under recovery, disease progression. So one of the and treatment burden. So a lot of times treatment for people with cancer isn't stable. It's dynamic in accordance to how their tumor is responding. So you could be on in this context of like metastatic disease, you could be on a maintenance dose of treatment and then they start to see disease progression. So now we have to go, it's really fast and it's growing out of control. We have to have a more toxic treatment to try and control it. So in the space of a couple of weeks, toxicity's through the roof, immune system shot even more. so their ability to recover is even worse. In addition to that condition I was speaking about, when you're working in the palliative stage or metastatic end of life, people are going to waste away, and you're watching it in front of your face. So in that context, the goal is the quality of life, and can we keep them out of bed a few days or a few weeks longer? But then in the same breath, you're seeing these people come into your gym being able to progressively lift less and tolerate the training load less, and ultimately some of them pass. And it's another thing that's unique about it, because you get so bought into people's stories and their journey and all the rest of it, and you become really close friends with them, as you do with most clients. But then to see them pass, it can be really difficult to deal with too.
Yeah, I mean, that's one of the biggest plights of any nurse or doctor is you kind of have to be disconnected your entire career, or else you would never survive, right?
Yeah, and I think it's hard with what we do, because at the same time you're trying to be that positive source in the gym for them. So, and at the same time, like, they'll say some reckless shit, because you'll be like, this is great, we're seeing some good improvements. They're like, I'm dying. Like, improvements for what? I'm going to be gone a few weeks. And you're like, you're not wrong.
Yeah. Have you had any issues mentally dealing with that?
It would be unfair to say I do. I get really sad. I inherently get really connected to people, and I certainly grieve their loss. I take a lot of solace from being a source of positivity in their life, and kind of giving them something to look forward to. But again, if you let it take over, it can take over, and it just becomes all consuming. So you have to find that balance. At least I'm trying to find that balance between being personable and bought into them and their story, but also not necessarily attached, but being able to kind of grieve it in a way that isn't paralyzing.
Yeah. That'd be difficult for sure.
Yeah. Because it can, you're in that group setting. So the group loses them. So you're in a group of another 6 people, and then the next session, where's so-and-so, and they're gone. So yeah, it's kind of part of the field, that it sucks, but it's still rewarding to work with them while they're working their way in, because some people can actually reach that age and be completely at peace, which is also really refreshing, to be like, I'm good, I'm 70s, 80s, lived a good life, I'm ready to rock. So one of the best things about it is that you've got 86 dads and 42 grandmas, and like they all really look out for you as well. So
they all bring you like little pieces of candy in their pockets all the time.
Yeah. We've got plans, we've got everything.
Yeah, I would assume also too, just being in that atmosphere allows you to appreciate your life on a daily basis as well. It can bring so much extra into your life. I talk about it all the time, being former military and stuff, and losing people, and that is one of the impetus of why I wake up every day with such a positive outlook on life and being so grateful for where I'm at. And I would have to assume that a job like that allows you to really have introspection of where you're at in life and what you're doing, and really just a lot of gratitude, right?
Yeah, especially in the context of academia, where some of the stuff that people complain about is laughable. Where second versus third author and stuff, and like, doesn't matter. It doesn't matter, you know what I mean? So it definitely helps give you that, or keep that perspective kind of refreshed more often.
Yeah, no, that's awesome. We appreciate your time.
That was amazing.
It was an absolute pleasure, lads.
Is there anything that we may have missed or glazed over that you wanted to touch on a little bit more?
Not necessarily, but if people are interested in this space, I have my own podcast called Reach, Research and Exercise in Cancer Health. Ignore the lack of episodes for the last 2 years, but there's a band of 70 to 75 where I've interviewed anywhere from terminally ill patients to the latest highest exercise physiologists in the space, or leading researchers in oncology, just to kind of put all this together in a form that people can learn from and appreciate. So anyone interested in that space, more than happy to recommend that, or reach out to me directly. More than happy to chat to people.
Yeah, are you taking on PhD candidates or anything like that at the moment?
Not until at least fall of 24. So
Okay.
we're consistently taking masters students, and if anyone's interested in this space as a PhD student, I'm happy to chat to them, because I have a bank of people that I regularly send, researchers that I send people if I can't fit them in, other people I'd recommend.
Perfect. But you guys are accepting master students at the University of South Carolina, is what I heard.
Yeah.
Okay, perfect. Yeah. So if you guys are interested in learning more, check out Dr. Fairman at University of South Carolina master's program. They are the top ranked exercise science program in the country. We did have one student from USF that just got accepted to their PhD program with Professor Dr. Arndt out there. So yeah, really, really good school. A lot of really good stuff going on out there. We appreciate your time. And hopefully that podcast gets launched here soon, maybe. I don't know.
Yeah, it's launched. Whether the relaunch will happen,
Yeah.
Fair enough.
Yeah.
So check it out, guys. And do you have Instagram where you post any research, or ResearchGate, or Twitter or anything like that?
Twitter is where I do most of my posting. Just Ciaran Fairman is where you can find me, and all my stuff is available on ResearchGate too.
Perfect. All right, make sure you guys go check them out. Thank you for your time, sir. We really appreciate it.
All right, gents. Great chatting to you.